And welcome everyone. Thank you very much for coming. It's fabulous to see you all here, and I'm really impressed with the breadth and depth of talent in this room in terms of health and medicine. So thank you all for being here tonight. It's fabulous. It's actually a very special night for the college. It's a unique opportunity for us to engage with one of the world's leading health reformers. And I think I really mean that, one of the world's leading health reformers. So it's very nice to extend a very warm Australian welcome to Dr. Ezekiel Emanuel, Professor Ezekiel Emanuel. And it's really delightful he's carved out time to be with us tonight. He spent the afternoon in a round table with some of us talking about megatrends and health reform. And he arrives really with a wonderful reputation within the global health community. So officially, Dr. Emanuel is Vice Provost for Global Initiatives and Chair of the Department of Medical Ethics and Health Policy at the University of Pennsylvania. He's also, and this is very important, a member of the Council on Foreign Relations and Chair of the Meta Council on the Future of Healthcare Committee for the World Economic Forum. Dr. Emanuel has studied at some of the world's most prestigious institutions, including Oxford, Harvard, and really has taught in some of the world's leading institutions, from Harvard Medical School, of course, UCLA, Johns Hopkins, Stanford, and New York University. And he's left an indelible mark on those he's met, both here in Australia so far and indeed elsewhere, and that's indeed why we've asked him to be here. But of course, Dr. Emanuel is really perhaps best known as a White House healthcare advisor. And indeed, he is one of the architects, one of the acknowledged architects of the Affordable Care Act of March 23rd, 2010, or if you like, Obamacare. And that's had an enormous influence, not only in the United States, but elsewhere around the world. He's written multiple books, many papers. He's been an architect too of discussions around megatrends in health, and indeed we're very fortunate to have him here tonight. There's no one better credentialed to talk about a number of the issues that will be covered tonight. And whether you agree or disagree with the points of view, to have the opportunity to engage, debate, discuss, consider, I think that's really important for all of us here and all of us around the world, thinking about what's best for healthcare and best in healthcare. So please welcome Dr. Emanuel and Dr. Swan back to the stage.
Welcome to Australia.
Thank you.
So where are we at with the Affordable Care Act? Because it's been evolving for the last 5 years. Where it was 5 years ago is not exactly where it is now.
Well, so it passed 5.5 years ago, almost exactly. And I think, to the shock of most people, it's been more successful than most of us had expected. Just whatever metric you want to use, if you want to use the metric of did it get people insured, right prior to opening of the exchanges and expansion of coverage in 2014, the uninsured rate in the United States was about 18%, and the most recent survey, it's 11.6%, and it would have been below 10% had more states expanded the Medicaid option, and that's a sort of inside baseball. So we've had a big drop in the number of people uninsured in the United States. If your metric is improving quality, we've had some big improvements in quality, drops in the readmission rate to hospital, drops in the hospital-acquired conditions, infections, falls, medication errors. If your metric is cost control, the last 5 years have been historic over the last 50 years period of cost control. Now, the last couple of quarters have seen costs come up, but again, we've had major cost control. Not all of that is the Affordable Care Act, but some of it is, probably a third or 40%. And then it's had no negative impact on the economy in terms of affecting employment that many people predicted.
Has it had the positive effect that people predicted, given that the bankruptcy rate, there was a perceived, the bankruptcy rate was considered higher in America than elsewhere?
We actually haven't, so the question is, the number one reason for bankruptcies personal bankruptcy in the United States had been medical bills. We don't actually have good data yet on that, although a study out of Oregon where they gave people Medicaid showed that among the people who got Medicaid, there were fewer bankruptcies and much better economic stability and less economic stress. So that aspect of financial protection seems to have increased.
And there's quite a few states that aren't playing ball. What happens to the uninsured in those states?
So those people, they all have exchanges because the federal government created.
So an exchange was where you can go and choose your health insurance company.
Right. So an exchange is something that will be coming to Australia soon, I predict. But an exchange is basically a online platform, a marketplace. Private insurers offer set plans inside defined markets, so the plans are pretty standardized and you can make some comparisons. And people are then can go on there and purchase. If your income is such that you can't afford it, the government gives you a subsidy linked to your income to buy it. So at the very low end, say 133% of the poverty line, you pay 2% of your income to buy the insurance. At the high end, at 400% of poverty, you pay 9.5% of your income to buy insurance.
And then it's compulsory.
There's a mandate and a penalty. Exactly how compulsory and how... We haven't been great at enforcing that mandate, and I think that's one of the things that we probably have to take more seriously.
So basically you use the federal exchange if you're in a state that's not playing ball with the Affordable Care Act.
That has not decided to make its own exchange. So, you know, there have been states that have been pretty successful about doing their exchange. Kentucky, California, Connecticut. And then there are many states like Texas or Florida that decided they weren't going to play ball, and the federal government stepped in, and we know that the initial rollout of that exchange was pretty much of a disaster. Now it's become much better.
So what's improved quality? Is it the Affordable Care Act that's improved quality, or there are a whole series of other measures, you know, studies of appropriateness of care and other things that happened?
Right. So there is some secular trend that infections were dropping and other things, but the Affordable Care Act had two penalties in them. One was on readmissions, which came into effect first, and that was basically if you're so for historical time, readmission, that is discharged from the hospital and then within 30 days readmitted to the hospital, had hovered between about 18.5% and 20% for patients on Medicare. We created a penalty that if you didn't drop your readmission rate, 1% of your Medicare billings would be at risk. Now, I was totally against 1%. I thought that's just not enough. You got to hit them between the eyes, and you need to make it 10%. That was what I wanted.
You cruel bastard.
Yeah, well, you want to get people's attention, you have to make it hurt. Turned out I lost that debate. I lost many debates, and it was 1%. And guess what? They still pay attention, and that's because a lot of hospitals, their margin, how much they're making, is either negative or it's 3-4%, and so a 1% hit really matters. So that's a drop. We also have a penalty if you don't improve your hospital-acquired conditions, 15 different conditions like infections, medication errors, falls in the hospital. You will also get a penalty. If you're in the bottom 25%, you will be penalized. That has gotten a lot of hospitals' attention.
So with the readmission rate, how do you know patients aren't languishing at home because your primary care system isn't quite as advanced as ours? So, you know, they're just falling to the cracks. I take umbrage at that.
So, I mean, it's a good question as to whether people are sicker going to the hospital or going to the doctor. We are measuring...
So you're measuring patient outcomes when they're not being readmitted?
Look, some of the decline in readmission is gaming of the system. You know, you give hospitals an incentive, they'll figure out how to get around it. They bring them into the emergency room, they watch them for 24 hours instead of admitting them. We know that that's going on. But some of the decline is real and genuine, and there, again, you have other metrics that you can assess when they go to doctors. I mean, one of the things the Affordable Care Act has put in place is a lot more assessment, and the recent, there was a recent bill passed to change how doctors were paid in the system for Medicare, and that is going to bring in a lot more assessment about quality and outcomes and link that to payment. And so we're doing a lot more general assessment of quality.
So tell us more about that, because we're obviously, as you know, going through various inquiries which are talking about changing the way some doctors are paid.
So one of the big changes that has happened, and I think one of the mistakes that we didn't put in the Affordable Care Act, a lot of us wanted in the Affordable Care Act, acting in the legislation, was a commitment to move off fee-for-service. We think that fee-for-service, as the ARGOT has it in America, incentivizes quantity, not quality, volume, not value, and so we think you got to, and it's especially pernicious in the United States where we don't have a global budget. Most other countries that have fee-for-service have a global budget that constrain that volume and that more quantity. And so most of us think you needed to move off that. And if you're running a hospital or you're a doctor, your commitment to move off that depends upon, well, what's the glide path, as we say, for shifting away? We didn't give anybody a glide path. We didn't say, all right, you can actually shift your practice, and we are going to assure you, here's the shift that's going to happen, and here's the timing. And so lots of doctors and lots of hospitals have been hesitant to invest heavily in changing the processes of care to be more value-based because they didn't know whether it was real or not. One of the things the Secretary of Health and Human Services, our Minister of Health, did after a long campaign by many people, including myself, was to say, all right, we're going to give you a schedule for shifting off fee-for-service. By 2018, half our payments in Medicare are going to be not fee-for-service, and that has had a profound impact. Second thing that the government did is to say, you know what? We were given authorities in the Affordable Care Act to change payment, and we are going to do, for the first time ever, a mandatory experiment. You don't get a choice whether you participate or not. It's mandatory experiment and bundled payments for hip and knee replacement. That, it wasn't mandatory across the whole country. It was mandatory initially. They said 75 marketplaces. It's actually 67. That has sent a shockwave to everyone because the way it was designed is it's guaranteed to save money and guaranteed to improve quality.
Because the prices are too low or low?
Well, they took a haircut. Yes, they put in we're going to take money off the table. Everyone said, aha, this payment change, this schedule that the secretaries announced, this is real. This is not a game. And so you've seen a lot more participation now in these experiments. So they've announced a cancer bundle, which, again, I worked heavily to get them as an oncologist. 250 practices have signed up for it.
What does that bundle look like?
You're getting, so that bundle is to cover things like adjuvant therapy for lung cancer or breast cancer or colon cancer. And the dollars will pass through for drugs, but you'll get a bundle for all the physician office visits and tests. And by the way, you'll be at risk for total cost of care. So if you don't bring total cost of care down, you don't save as much money.
So it's got the flavor of an accountable care?
It's got the flavor of you're responsible for putting the whole package of care together and for saving money, because if you save on the total cost of care, some of that savings will come to you. So that's I think, a very powerful incentive for doctors. And in cancer, it's very high cost, but there's also a lot of variability and a lot of ways to save money.
What about outcomes and payment for outcomes?
So payment, most of us don't know exactly how to do payment for outcomes. We can monitor quality. We have, HEDIS measures for 64, 66 outcome measures. We're shifting to more to process measures that are linked to outcomes and to more outcomes measures. That shift is going to take time. It just is. And in cancer, look, take cancer. What's the outcome? 5-year survival? Who's going to wait 5 years to get their payment? So what you need in cancer is a measure that is meaningful. So I'll give you a measure I'm a breast cancer doctor, is did you select a preferred chemotherapy that's been certified by the National Comprehensive Cancer Network as preferred for breast cancer? Did you do the right tests, say genetic markers for some people? And have you delivered that dose of care of chemotherapy to patients? So did you give them the dose density that's expected, or did you not? And then we're
So it's tightly bound to guidelines, essentially.
Yeah, yeah. Did you adhere to the guidelines? And also, we're then going to monitor, you know, patient-reported outcomes. How much nausea, vomiting did they have? Were their symptoms managed? Hospitalizations, emergency room visits. So trying to optimize both the chemotherapy, but also the management of side effects and things like that.
Now, you didn't describe what the payment's going to look like for the more general physician or the primary care physician.
Yeah, so that's a shifting off fee-for-service to another alternative payment model for a general physician is challenging. I'm in the midst of participating in a study of an experiment in Hawaii where we're trying to shift all of Hawaii's primary care doctors to capitation. So they'll be capitated. They'll get a payment per month for each person with some risk adjustment. We're then also going to measure their quality, and they'll get quality bonuses based upon, we're trying to get a small number of measures, less than 20. And then they'll also get a payment if they save on total cost of care. So that's the kind of shift we're trying to do.
So we'll come to one of your megatrends in a minute, which is this is related to, because you talk about the VIP care of people with chronic disease.
Illness, yep.
So here we're arguing that that shift from episodic care to continuous care, that bundle payment is probably the right way to go. What do you do about acute care within that changed payment system? The person who comes in with a broken arm, the acute upper respiratory tract infection, the young person who's only going to be seen once that year. Still in capitated payment, or do you still keep an element of fee-for-service?
No, I think you don't want to keep an element of fee-for-service. You do want to keep a capitated payment and, again, hold the system, the physicians, overall responsible for the total cost of care of their pool, not any individual patient. And I think that's going to be a much more effective method than to keep an element of fee-for-service. Because if trying to blend capitation and fee-for-service, you're going to make most doctors schizophrenic, and I think you're not going to get the full bang of the value-based focus for them. Look, let's just be honest. 83%, at least in the United States, and I would bet it's almost identical in Australia, 83% of spending is for people with chronic illness. It's not for acute care. So, you know, the big bulk of the payment is for these patients. You know, 17% you will fit in if you get the 83% right.
So before we move on to megatrends, just talk to me a little bit about untoward consequences. Because as you've already alluded, health systems here over in the United States are fantastic at gaming. You give them a target, they'll game it.
Right.
4-hour, NEAT targets, NEST targets we've got here, surgical waiting list targets, they game it.
Right.
One hospital here a few years ago had a 9-month waiting list for pregnancy.
Shocking, isn't that?
Create a waiting list, we'll make money out of it. How do you steel belt against gaming where the patient is the pawn in the game?
So it's one of the reasons I try to educate policymakers around. There's no such thing as we're done with healthcare reform. Healthcare reform is a continuous process, in part because the system will game. I mean, when you have tens and hundreds of billions of dollars at stake, right, you're going to attract a lot of smart people who figure out how to maximize returns because it's worth billions of dollars. So you have to constantly be adjusting and looking for problems and solving problems. So one of the points I make is we're not done with healthcare. We now have to be on to healthcare reform 2.0 in the United States that is going to plug some of these problems and some of the unintended consequences. There is no, I mean, one of the things...
So you don't set and forget.
You cannot possibly do that. And you cannot say we're done with healthcare or we've done the reform. You've done a reform and 2 or 3 years or 4 years later, you're going to be back doing more reforms because you are going to find these unintended consequences and you are going to find better things that you want to incentivize.
Now, you've got 4 megatrends for non-US countries.
Yeah, right.
VIP care for people with chronic illness.
And mental illness, by the way.
And mental illness.
I don't want to lose that.
A digital medicine revolution, which will result in the closure of hospitals.
Correct.
The end of healthcare inflation.
Correct.
And radical changes to medical education.
Correct.
Which is where we're going to get to today eventually. But one I want to talk to you about from your American list, which is 6 megatrends, is the end of health insurance as we know it.
Yep.
Just talk to us a little bit about that.
Okay. So in the United States, everyone hates their health insurer. Why wouldn't you? All they end up doing is taking your money and denying you care, right? No one likes their health insurer. If you look at the trend going forward and you think we have to get to more value, in other words, we need to increase the quality of care and decrease the cost, or at least constrain cost increases over time. Insurers, if they simply pay the bill, they get the claim and they pay the bill, you're not going to be able to change the system. So what's happening in the United States? Providers, big health systems, are getting into the insurance market. They're integrating care from primary care to tertiary care to rehab, and then they're adding the risk. So they're looking like integrated delivery systems. They're looking like, in the United States, Kaiser, where they
effectively self-insuring.
Not self-insuring. They're taking the whole range of care. They're getting a capitated payment because they're getting the premium. So just to give you some examples, Mount Sinai in New York is offering what we call a Medicare Advantage plan, which is an insurance product for people over 65 who are on Medicare. Long Island Jewish, which is another big health system on Long Island in New York, is offering itself on the exchange. Presbyterian Hospital in Albuquerque contracts with Intel to take care of all of its 5,500 employees in Albuquerque, so they have a capitated payment. So basically, these places are acting as integrated delivery systems, offering themselves on the exchange. Well, if you're an insurer, you've got to actually go in and you've got to align yourself with providers. You either have to be an integrated delivery system yourself, or I think you're going to go out of business. And is that happening? And the answer is yes. Recently, Anthem, second biggest for-profit insurer in the United States, coordinated in Southern California, in the Los Angeles area, with UCLA Medical Center, Cedars-Sinai, which is the hospital to the stars, and 5 community hospitals to offer an integrated product that they would have a joint venture all together to take care of people and list themselves on the exchange and offer themselves to individuals and employers. Why? Because they're competing directly against Kaiser. This kind of thing is happening more and more, and insurers are going to go in that direction.
What happens to medical power in that paradigm? In Australia, politicians run scared of the proceduralists.
Yeah, we all should.
And they, holding us to ransom.
Right.
Get rid of fee-for-service at your peril. Right. We're going to go on strike and just exclude ourselves from the system. That's the conversation, the quiet, unassuming conversation we have in Australia. Yeah. Do you have that in the United States?
You do. You have some doctors who say, I'm never going to take Medicare. Again, payments too little. You have what we call in the United States concierge medicine, right? I will charge you $1,500 or $3,000. I'll be available 24/7. You email me. I'll come running. Yeah, that will work in New York and in Los Angeles and a few places where there are enough people who can afford that. But it won't work nationwide, and it's not a key part of the healthcare system. So I don't think it's a credible threat in the United States. You really can't exempt yourself from Medicare. You can't exempt yourself from insurance except in a few areas. So you're still going to have to play the game. So what we're going to see in the United States is something different, which is what we call narrow networks, high-performing networks. That's going to be the next phase of our reform, where the bottom end, people who do a lot of procedures that seem unnecessary, high variation, people who seem to see their patients a lot and aren't very efficient in care are going to be excluded from the network. Hospitals that charge a lot and don't seem to give better outcomes are going to be excluded from the network. That's going to be our next phase.
So really exerting market power
exactly
over low-value care.
Yeah, right.
Let's move to VIP care of people with chronic illness.
Yeah.
What does that look like in your mind?
So,
and mental illness. Mental health issues.
It'll occur in phases. So the key thing to understand is 83% of dollars are spent on people on chronic illness, and that's not evenly distributed. So in the United States, and again, I don't have the data here in Australia, but some people in the audience I'm sure do, 2% of the population, or 50% of the population uses about 2% of healthcare costs, right? They're young, healthy people.
So here it's 1%, 30%, 10%.
67%.
Yeah.
So in the United States, 10% of the population, 2/3 of the spend, right? So if you want to improve quality, you want to decrease costs, you got to focus on the 10%. Like the famous American bank robber, Willie Sutton, when asked why he robbed banks, said, that's where the money is, right? So where's the money in healthcare? It's for that 10% who are multiple chronic illnesses. You got to focus on them. You got to use tertiary prevention, keep the diabetic from getting sick, keep the cancer patient from having severe side effects that has to be hospitalized, and manage them on the outpatient setting. Places that have done that in the United States are anywhere from 15 to 30%, say 15 to 30%. How do they do it? They focus intensive effort on people with chronic illness to keep them healthy and out of the hospital. They have, for example, diabetic wound care. Someone gets a cut on their foot. They don't just have their primary care doctor look at it, so they look at one a week and they're not very good at it. They have the best nurse. Then they concentrate these patients. They all go to the best nurse to take it better. Similarly, they run warfarin clinics or Coumadin clinics so that patients who are on blood thinners, they have the best nurse manage them. Really complex, chronically ill patients, they don't leave it to the primary care doctor. They take it to a doctor who loves managing these super complex patients.
So I think we all understand that sort of high-intensity, team-based care. But there's another issue there, is that the evidence from Australia is that 10% in 2015 is not the same 10% in 2016. There's a churn, and unless you take a population health approach, you're actually going to always get caught out. How do you integrate
So first
that?
of all, there's not 100% churn, and the churn is less than 50%. That's the first thing. It is true there is a churn. A lot of high-cost users are people who newly diagnosed cancer or have a heart attack out of the blue. So you oversample. I mean, the question is, you don't treat the 10, you can't focus in on the 10%, so you treat the 15%. Let me give you an interesting, there's a company in the United States called Aspire, private company, working on end-of-life care. And they've got their own algorithm. And you ask the guy, so how good's your algorithm? It's only 50% good. Really? How can you make money if half your patients aren't going to die and you're being paid to, well, we then take that 50% and we talk to the doctors who have a really good, they don't have an algorithm, but they have a nose, right? Yeah, this patient going to do okay, right? Your algorithm picked them out, but not the right one. This one's going to do much worse. And that substantially improves their algorithm, and they're able to reduce hospitalization in the last year of life by 50%. All right. So you'll have to take some of these algorithms, and yes, you'll oversample. You'll get 15 or 20% of the people, and you'll focus your care on them.
And the incentives to create that VIP care?
That can only work if you're not getting fee-for-service, if you're getting capitation. Because then you say, look, we're going to load on. I mean, where are the savings when you look at places that have succeeded in doing this? We're going to load on outpatient services, and we end up reducing hospital use, reducing ER visits, reducing expensive specialist visits. Those are the three places that you save money. So the transfer is low, and this goes to the digital medicine and closing hospitals, lower hospital utilization, and you save that money, increase outpatient care, more team-based care, higher salaries for your primary care doctors.
So now that I realize that I'm doing this interview in the College of Physicians and not the College of General Practitioners, the fellows of this college there's a lot of fellows of this college
They're going to benefit.
Who are in private practice.
Oh, yeah.
Private cardiologists, private gastroenterologists, private diabetologists, working in the rooms. Sometimes they've got a nurse working with them or a diabetes educator. A lot of the times they don't.
Yeah.
They're isolated. Some of them aren't very well computerized.
Right. Right.
They're certainly not being trained in team-based care.
Yep. All of that's true. Yeah. So this kind of healthcare reform will take longer in Australia than it will in the United States. And the other big problem, I mean, we have our own.
So how do we get from here to there?
Okay. We have our own big barriers in the United States getting here to there. And just to tell you what those barriers are, if you're a doctor, 30-40% of your billings will be Medicare. Then you'll have a bunch of private insurance where you're making most of your money, but that'll be chopped up. Some of it will be, a Blue Cross plan. Some of it will be an Aetna plan. And you're getting different signals from everyone. So we have a problem with integrating the signals. On the other hand, from the payer standpoint, you will save, if the doctor reduces hospitalization, you'll save money, and you'll be able to incentivize the doctor. So we've got the doctors and hospitals from the same payer. Here in Australia, as I understand it, you've got it all mashed up in a different way, which is someone pays the doctor, like the federal government. State government or provinces or whatever pay the hospital, and then there's this private component which screws it all up, right? It makes it hard to integrate because the savings on the hospital side will go to the state, right? Won't make it easier for the federal government. They'll see the rates go up. So you're going to have a barrier, and that has to be integrated. The payment somehow has to be so that the savings, when you reduce hospitalization, can be transferred and incentivized to the doctors. Otherwise, it ain't going to happen. Now, on the private side, I don't understand that much about the private, but you're absolutely right. Doctors working individually cannot do this transformation. They have to be aggregated. And I'll tell you, when we're working on trying to transform the primary care doctors in Hawaii, they're still onesies and twosies and threesies in practice. And one of the things we're going to have to do is incentivize them to amalgamate and to create a physician organization that can help them with the electronic record, that can help them with other services. We're trying to get the payer, for example, the insurance company, to offer dietary services, to offer mental health services, to offer smoking cessation services, to offer exercise programs, so that the doctor, when diagnosing one of these problems, can refer and will actually provide some of this ecosystem that is necessary. In Australia, you will have to get these doctors, you'll have to provide some incentives, I can imagine what they are, for them to amalgamate, for them to adopt electronic health records, for them to actually use the data, to give back some of the data to them so that they understand their bad practices and good practices.
So this college, which sets standards for training, you've got this legacy group of fellows
Absolutely.
Who've not been trained to do this stuff.
Right.
Does this college have to tool up for a very different set of postgraduate training schemes?
Oh, I think not only this college, I think that's so we have two problems. One is we have an existing pool of tens of thousands of doctors in the United States, hundreds of thousands, who many of the skills they'll need for the future healthcare system simply weren't trained in that. But we also have a defective medical education scheme going on simultaneously, so we keep generating doctors who aren't sufficiently well trained. I mean, one of the things I think, and I've advocated in the United States, first of all, we train way too long in medical school, and we train on the wrong things.
So you advocate a 3-year course?
Yeah, and I think it's inevitable it's going to happen, but also a 3-year course with different kinds of training.
So what does a 3-year course look like?
1 year of preclinical, pathophysiology, genetics, anatomy kind of stuff.
So you're assuming they get a lot in pre-med before they walk in the door?
We need to train pre-med too, of course. But one of the things, I like to say is I learned the Krebs cycle 6 times, I counted, in pre-medical training and in medical school. I've used it 0 times. I've used a lot of statistics. I trained not at all in statistics in medical school.
I had to do physics in first year.
Yeah, exactly. No, we have a year of physics, a year of organic chemistry, and I said, not really helpful to being a doctor. And calculus, too. We had a whole year of calculus. I said, I never did one differential equation while I was a doctor. Never once, right? Mostly I had to calculate, body surface area for chemotherapies. No one ever trained me how to do that, right? So we're going to have to change a lot of that. And I think
so the nervousness in this room is if you compress it, you don't see enough clinical, you don't get enough clinical experience.
No, but one year is preclinical. You're taking 1 year out that's preclinical. By the way, Duke, Yale, Harvard, Penn, all the major medical schools, not all, but many major medical schools in the United States have compressed their preclinical to either 1.5 years or down to 1 year. So we already know you can train very good doctors with only 1 year of preclinical. Then you get to the clinical side. Mandatory required clinical courses, surgery, OB-GYN, pediatrics, internal medicine. That stuff takes about 1 year or 15 months in the United States. Then you can add on, 2 years of clinical is fine. And
non-hospital clinical experience.
Well, non-hospital, right. I mean, if most care is going to move out of the hospital, and I think that's also inevitable, the idea that you do all this clinical training in a hospital seems a little wacky. Now, no hospital that I know of has no medical school has fully figured out the outside of the hospital training component. It is a lot harder, but if we don't start now, we're going to have to do it inevitably. We're also going to have to train people in digital medicine, in telemedicine. Those things are coming. We all know that.
And management.
Absolutely. I think if you ask me what's the single most important thing I think most doctors ought to have that we don't do now, process improvement and learning how to lead teams. Those are going to be two skills that are going to be absolutely essential that we give zero training to. I was supposed to teach this past September the first course we were going to offer, a week intensive sort of an executive training to our medical students on process improvement. I was going to co-teach it with a guy from Wharton Business School. He unfortunately got sick, and so we'll have to postpone the launch of that program. But I think that's absolutely imperative for us to understand, how do you do lean in a hospital? How do I process improve
so
my
if your
own
ambition is
practice?
to become a plastic surgeon, you're going to buy into this? Or you've got no option?
Who cares about plastic surgeons? Let me be serious. They're going to make a ton of money no matter what we do in the healthcare system because, people are vain. And we really don't care about plastic surgeons. What we do care about, and they usually, I don't know about Australia, but it's all private pay for plastic surgeons, right? It's cash on the barrelhead. And the healthcare system won't rise or fall. Usually you don't even count plastic surgery in your medical accounts. Right, but it's the primary care doctor. You will care about this. It's the cardiologist, it's the GI doctors, it's the oncologist. And let me give you an example, right? You would say, orthopedic surgeons, why do they care? You have a backlog of how many months? 3 or 4 years to get a hip replacement?
There's people who will do it for you tomorrow if you want, if you've got the money.
Always about money. Doctors are above money, but it's always about the money. Yeah. So there's a institute out in Orange County, California. For those of you who don't know, Orange County is between LA and San Diego, one of the most conservative counties in the United States. Not the place you look for innovation in healthcare provision. There's a group called Hoag Orthopedic Institute. I wrote about them in Fortune. And these guys have process improved their delivery of care unbelievably. So they've done time motion studies, where they're spending their time. They've done variability studies and where is the variation in care. They flip an operating room. First of all, they never cancel a case. They do a pre-workup. Patient has, and they swab people for MRSA. Patient has MRSA. They go through 2 weeks of cleaning them to make sure they don't have it so that they decrease their hospital infections. They never scrub a case. Every patient with cardiac disease or something is worked up before. They flip operating rooms in 22 minutes. They never re-sterilize any piece of equipment. They have newly sterilized equipment for 5 operations in a row so that they don't infect someone by inadequately sterilized equipment. They're phasing out rehab in the hospital because it's too expensive. They do rehab at home. They require patients to come in for education before their hip and knee. They follow every patient for a year, getting their patient-reported outcomes. How much pain are you having? Are you back to golfing? Are you redoing your physical activity? Their satisfaction scores are through the roof, better than the national average. Their hospital-acquired infections are about 1.4%, where the norm for orthopedic surgery is about 5%.
And the costs?
$22,050 for a hip or knee without the rehab. And it's up on the website. You can see it transparently. Their quality
Standard
indicators.
price. And how does that compare to the mean in the United States?
Pretty good. And by the way, the surgeons are doing really well, and I can tell you how well they're doing. So I go there, I look at the place, and I said, I just don't understand you guys. You're operating, you're supposed to be super efficient people, all into the time motion study. Why are you only operating 5 days a week? You operate maybe 55 hours out of a 168-hour week, right? If you were really into efficiency, what's wrong with Saturdays? What's wrong with Sundays? What's wrong with operating till 10 p.m.? They don't need to do it. I said, well, why don't you hire new or, the most expensive piece of equipment you have is that operating room, which you bill by the minute, by the way, right? It's so expensive. Why don't you keep it going, 100 hours a week instead of a mere third of the week? you know, we're making so.
They're well enough.
So I said, hire new guys where what you tell them is, you know, you got to do Saturdays. And by the way, you also have to do Sundays. So they're thinking about it.
Talk to me about digital medicine and the closure of hospitals.
So here's what's happening in the United States, and I think it'll come to Australia too. You're going to decrease hospital readmission because you're going to focus people on making that handoff after the hospitalization good. You're going to decrease hospitalization because the rate of infection is going to come down, the rate of falls, untoward events is going to come down. You're going to keep patients on the outside healthier who have chronic illness, reduce their rate of hospitalization because you're incentivizing for value. That decreases the flow to hospital. Simultaneously, you're going to be able to monitor people, chronically ill people, more, get a jump on things like that wait for that congestive heart failure patient's going up. We should call her. We should send a nurse practitioner or a home health aide out to look at her. You will also, I think, have people not coming to the emergency room because you'll have interaction on urgent care over the internet. We know that we have a lot of companies trying this in the United States, Stat, Med, Carina in Seattle. Most of those, 75 to 80% of those interactions over the web on urgent care can be handled over the internet, forestall visits to hospitals. And we know that if you visit the emergency room, many patients are admitted even though they don't need to be admitted because of uncertainty. All that is going to decrease the hospital utilization and drive down the need for hospital beds. I don't know how overbedded Australia is.
Grossly.
Yeah, well, all countries are because hospitals have this amazing ability. People love their hospital. They want it there. Politicians very hesitant to close them.
So are any closing now?
Always ways of propping up.
So you're seeing signs of that already?
Yeah, you already are seeing signs of closure. Now, you don't just close a hospital. You shift it to outpatient facility, urgent care, doctor offices. But here's the secret in America, and again, I don't know enough about the Australian system. In the United States, no government is going to close a hospital. Medicare will not say, we're closing that hospital. We have the bond market who will close hospitals. They're going to say, you know, I'm looking at your balance sheet, and this just doesn't make any sense. I'm not loaning you any more money. And I'm certainly not loaning you at, you know, AAA rates. You might be BBB rates, in which case you can't afford. That's what's going to close and consolidate hospitals in the United States. Predominantly, we're going to have a lot of rural hospitals, 25-bed hospitals that really are not doing that well.
So what's the role of, you don't talk a lot in your books about the role of the consumer in all this.
Yeah.
So all this is top-down.
Well, it's not top-down, but so I don't concentrate a lot of my effort on trying to get the consumer more savvy about buying, and for two, maybe three reasons. The first reason is, again, as I mentioned, 10% of the population with chronic illness accounts for 2/3 of the dollars. That 10% tends to be older, not so well educated, and not in a shopping mood, right? They're not shopping. They've got multiple illnesses. So they're not a great target. Now, you and I, okay, we're relatively healthy. We don't use that much care. I'm making assumptions about you. You know, we can shop, but we're not using that much health care.
It's not necessarily about shopping. It's about self-management. It's about asking the right questions of your doctor.
Yeah,
it's about pulling good care.
Yeah, well, I don't think it's much going to be patient-driven. So I'm focused on doctors and focused on wanting doctors to deliver good care. And I think if we focus on doctors, well, let me finish my third thing. When you make patients responsible, now we had this big, I think, 6-7 year flirtation now in the United States with having patients have more skin in the game, paying more for deductibles, paying more for co-payments. What do you call it again here?
Out of pocket.
Yeah, no, you have another term. Gap, right. Right. We know what ends up happening. We have a lot of good data now that what ends up happening when you have patients more responsible for bigger portions of the gap is they cut back on necessary and unnecessary care. They're pretty bad consumers. No surprise. We've known for a long time. You put financial barriers, people will forestall preventative services like colonoscopies or mammograms that are good for them or vaccines. So I don't actually invest that much effort or thinking about how to incentivize consumers. I think we got to focus on the doctors. They, after all, write the prescriptions, write the orders for tests. They control 85, 90% of the spend. And we need to deploy 3 different mechanisms. We talked about this just before this. One is you need to give them the financial incentives to actually focus on cost-effective, value-based care. Second, you need to rely on their sense of prestige and personal. They want to be outstanding and they want to be at the head of the class. You need to show them the data about their own performance relative to the peers that they care about. So social comparisons, very important. Most doctors, dare I say, have no idea how they're practicing. We think we're doing a good job, right? Otherwise, we couldn't get up in the morning. But we really don't know if we're doing a good job. You know, I had no idea when I regularly practiced oncology, you know, how frequently my patients were hospitalized because of side effects compared to the next guy, or how often my patients died at home compared to the next guy. I had a sense I was doing well, but I really didn't have any data. We need to give them data. And the last thing I think we need to do is we need to entrust them and measure their outcomes. We can't just make lots of process-oriented barriers to them. In the US, it's like prior approvals for this and that. You know, put them at risk for total cost of care and equality.
And let them get on with it.
And let them get on with it. So I think those are the changes, and that's where I focus my efforts. I think that's going to yield much better returns than trying to make patients responsible.
I'm going to take some questions from the floor in a minute,
Please.
but I can't let this go because
I know.
The right, you know what's coming. The right in the United States called you the death panel guy.
Dr. Death, I believe, was the technical term.
They were much polite, yeah. What is your position on euthanasia, physician-assisted suicide? Where did all this come from?
Well,
are you the most misunderstood Dr. Death in the world? You know?
No, not necessarily. I have spent, since the mid-1980s, I've worked on end-of-life care. And I've tried to figure out ways to improve end-of-life care because I thought we were doing a bad job in the United States. The Dr. Death thing came because we were investigating. We never put into the legislation or even suggested, but we were investigating various ways we might improve end-of-life care in the United States, paying doctors to have a conversation with patients about advanced care planning, making palliative care available, requiring every hospital that got Medicare money to have palliative care in the hospital, et cetera, et cetera. And that's what they said, you know, Dr. Death, and then they said, you know, he's going to have death panels for you. So it was pretty misunderstood. I will just say I took a lot of attacks from some reputable places like the Wall Street Journal and from some unreputable places like Sarah Palin and some of our representatives from the right. But recently, Medicare has said that they're going to now have a billing code where doctors can bill for having a discussion on end-of-life care. And not a squeak in the country. Not a squeak. I took all the bullets, and then, you know, they could do it without any problem.
Bleeding
So I am very much into thinking about how we can improve end-of-life care. Now, people, it's like, you know, well, that must mean he's for euthanasia-assisted suicide. And I've been against legalizing euthanasia-assisted suicide for these last 25 years, since I've done a lot of at least in the United States, a lot of the basic research on it. And I'm really against those interventions for 3 fundamental reasons. The first is, if the question is, how do we improve end-of-life care for people who are dying in our country, the 1% of people who die each year, the answer is not euthanasia-assisted suicide. Because even in places like the Netherlands, which has legalized and permitted these procedures for many decades, 2.8% of the population dies by euthanasia-assisted suicide, right? That means 97% of the population, this is not the answer. So if you want to improve end-of-life care, you don't focus on the 2%, you focus on the 97%. That's the first. It's not a solution to the problem. There's a much bigger problem out there. Second, if you look at what motivates people to be interested in euthanasia-assisted suicide, it's not what most people think. I noted there was an article in the Sydney Morning Herald, about a Q&A program where they quoted part of the Q&A program, and they said, yeah, if if life becomes unbearable, if my pain is excruciating, I want to be able to end it. And most people say, well, yeah, that's when you use euthanasia-assisted suicide, when you've got extreme unremitting pain. Turns out that's completely wrong. And we've known for the last 20 years that's completely nonsense. The patients who want euthanasia-assisted suicide turn out to be patients who are depressed, hopeless, tired of life, mentally. Euthanasia-assisted suicide looks more like regular old suicide, just with the cover of it's done by a doctor. And our usual answer to patients who are depressed or hopeless or tired of life is not,
Murder. Yeah.
You should die. It's you need therapy, and let's get you some therapy. And the last point I would make is a lot of people think these interventions are quick, painless, and flawless. And I've always said, I don't know a single medical procedure, even drawing my blood, that's quick, painless, and flawless. They all have a flaw rate, and sometimes more than others. And if you look at the data, there are, patients who wake up from these procedures, patients who take 4 days to die from these procedures, patients who you can't actually do it because they can't swallow the medicines, you can't find a vein, et cetera. There are both problems and complications to this, and it's not quick, painless, and flawless 100% of the time. I think people, don't understand these basic elements. Typically, the people who want this passed, and the reasons these legislations get passed is they tend to be white, upper middle class, if not rich, well-educated, used to controlling everything, and they want it for themselves. And they have the ears of politicians, and that's how it happens. And many other people think somehow it's the solution to end-of-life care. I just don't see it that way. And I think, it's interesting. Most oncologists, most palliative care doctors aren't for legalization. Tends to be surgeons and other types who, like quick, definitive answers, who tend to be for it.
Really? Surgeons? I've never imagined that. Let's take some questions.
Wow, we've bored them all. What can I say?
Yeah. Peter Boone.
The politics of the Affordable Care Act now and in the future. Just tell us a little bit about it.
It's American politics. What can I say? It's very difficult to get major pieces of legislation through in the United States. The Founding Fathers created a system that any major legislation is hard, and we've made it even harder by the rule that you had to get a supermajority, 60 votes in the Senate to get legislation through. For a brief shining moment, we had that, and that's how the Affordable Care Act got passed. We worked very hard to make it bipartisan, and actually one of the things most people don't know is that in the Senate committee, Senator Olympia Snowe, a Republican from Maine, actually voted for the Affordable Care Act. And then her entire party came down on her like a ton of bricks, and she reversed her vote, even though the bill hadn't changed from what she voted for in the committee. It is very unlikely the Republicans will be able to repeal or change the Affordable Care Act for a whole series of reasons. They can't afford to do it. It would put a big hole in the budget, and they couldn't solve that problem.
Why would it put a big hole in the budget?
For the way we account for the budget. I mean, this is really in the interstices of budgeting. There's something called pay-go. You have to actually pay for legislation. If you repeal the Affordable Care Act, it turns out you will actually spend more money because the Affordable Care Act is actually saving money for the American healthcare system. So it's not a viable alternative. Nonetheless, they jazz up their constituency by saying we're going to repeal and replace. One of the points I have made, or two of the points I've made repeatedly, is first, the structure of the Affordable Care Act, those exchanges, subsidies, mandates, those are Republican ideas. They were all for them.
Because you wanted a national health insurance scheme.
No. The Republicans came up with that idea, an individual mandate, exchanges, private insurance subsidies by the government, until the Democrats embraced it. And then they became against it. So, as my brother likes to say, the politician likes to say, we were for it before we were against it. So, you know, it's a little bit of hypocrisy there. And the second is they never have had a replace option that has stood more than 24 hours under scrutiny. The moment they propose a replacement option, it burdens the middle class with even higher healthcare costs. It's not a viable option for getting universal coverage, higher quality, or cost control. It just, nothing they have ever proposed in the last 5 years has withstood 24 hours of close examination. And so I don't think it's, you know, they'd have to now take the insurance away from more than 10 million people, given any one of their proposals, and prices, premiums for the middle class would really jump if they introduced their proposals. It's just not a viable political option.
Yes. If you could just introduce yourself, that'd be great.
It's Rob Baum from Central Coast. Yep. Do you see the possibility of capitation fees, which is an alternative way to pay fees, which you see as coming in, I take it, setting the levels at which the targets for which you're paid for? That could be very important.
It is very important,
to see what level is accepted. Do we have the sort of minimum that's okay? Do we have a medium one, or will that be staggered? What do you see?
Well, I will tell you our experience in Hawaii in trying to figure out what the right, we call it PMPM, per member per month. How much are you going to pay per member per month? How much risk adjustment are you going to do? So what's the variability between someone like, you know, yourself, who's relatively healthy, and someone who has multiple chronic illnesses like diabetes and COPD and CHF? Setting that level is really hard. And then one of the things you see is doctors, no surprise, are all over the place. Primary care doctors, some of them are, you know, treating their patients at a PMPM of over $40 a month on average, and some of them are really super efficient down at $11 and $12 PM. And how over time you can bring them together so you have one or a small set of PMPMs is very difficult. I don't know yet. I mean, we're experimenting with how to do this and how fast you can bring it together. Can you actually bring them together over 5 years? What I would say is you are going to have to risk adjust them, and you're going to have to get enough good data on that risk adjustment. And I actually think the variation between PMPM for a relatively healthy person and one who's relatively sick is probably going to have to be 3, 4, 5 to 1. And we don't know exactly how precise it's going to have to be. And so you do also need a backstop. You need some reinsurance scheme to prevent doctors from going broke just because they get a sicker set of panels.
How do you set the level as to how well you want to get them?
So this is
I think that's actually
how perfect do you want the care to be?
Yeah, well, you want the quality metrics to constantly be going up, and you would like to get it to better than 90%, especially for things which you know are critical to longevity, right? Like blood pressure control, like hemoglobin A1C, like cholesterol levels. And it does seem to me we're unacceptable on most of those measures. So the way we're thinking about this payment is, again, they've got a PMPM just for breathing and being engaged in the system and looking at their data. Then we're going to have a pool of money, probably 25% of their total annual billings that's related to hitting quality metrics. So they could increase their... And then, beyond that, sharing in the total cost of savings. So if they bring the total cost of savings mainly by, you know, reducing ER visits, reducing hospital visits, total cost of savings, they could double their income. So if you take a primary care doctor and you say, you know, you practice value-based care and we're going to double your income, that gets their attention.
But this does go to an issue which you do talk about, which is that we train doctors and specialist physicians for perfection, that we, risk aversion, we want to be thorough and, delve into every corner and provide the highest quality care.
Well, I think there's a difference between providing high value and, doing a lot of tests to rule out what we call in America, I don't know what you call here in Australia, the zebras, the rare potential diagnosis for, what otherwise is likely to be pretty straightforward. And I think that's not that actually is not what we want to incentivize. We do want to incentivize constant process improvement and changing your processes of care so that known gaps in care are closed. And I think that's something that's going to be pivotal. And most of that, again, is if you ask, I would venture to say most doctors who are practicing in this room, pick out a patient, what are his or her gaps in care? Most of us couldn't say. We don't know how well we're doing, and that's not because we're bad people. We just don't have the data on our own practices. And until we begin to systematically collect the data, systematically look at the data, know the gaps in care before we see a patient in the office, we're not going to be able to improve care to the 90th percentile. I heard a statistic today, and you'll correct me, but on standard measures, 57% of the time they're met in Australia. We got a whole lot of way to get to 90% before we get to perfection. And so I'll worry about getting to the 90%, not the perfection.
The appropriateness of care study. Yes.
And
oh, boy.
I also have a role in the college and at the Clinical Excellence Commission in New South Wales. I'd like to take you back to your comments around the skills that we must be teaching our junior doctors, and in particular around process improvement and leadership.
Yeah.
We have curriculums that are overcrowded. We have days for junior doctors that are completely overcrowded, and we don't have a lot more money in the budget. So how do we give the junior doctors that we're training the skills they need to do the things you just discussed?
Well, we're working on an online course. I don't know if that's the answer. I don't think anyone has completely figured it out. There are some online courses about process improvement, but not necessarily focused on healthcare. And the second thing is, you have to ask your question in training, what is most important? And if this is oversubscribed and a lot of the junior doctors think it's super important to do, maybe we need to reallocate our funds from microbiology to this. Again, one of my standard lines is, they taught me about lentiviruses, and I have no idea why it made a difference in terms of treating most of my patients. First of all, we can't treat most viruses, right? And second of all, do I really care whether it's a lentivirus or some other kind of virus? A coronavirus? Not really. So I think we need to focus on, am I offending someone here? Good. So the question is, where do we really think by educating someone we're going to move the needle in a way that matters? Until we get treatments that differentiate between lentivirus and coronaviruses, it doesn't really matter, right, whether that infection is caused by one or the other. When we get a treatment that'll differentiate them, then I think it's, fair game. Until that time, it's irrelevant, really, to patient care. It might be relevant to someone who's doing research, but, that's not 99.9% of the people we're training. So why are we wasting time? And this is something we repeat over and over in our medical training. Again, I just asked the simple question, how many of you have ever used the Krebs? Now, a few renal guys probably have, but the rest of us, no way.
And the question is for the college, you're going to recognise a term in management to allow for your primary. And in Western Australia, PGY 1 and 2, they allow for a term in management. And the Postgraduate Medical Council has accepted that. Yes. And then I'll come. Oh, we'll take you first. You've got the microphone, and then we'll go to the back.
Tanya Markovic, endocrinologist. I have used the Krebs cycle, but I'm listening to you, and I agree with you because I think there's a lot of gaps, and a lot of what people are taught in medical school, I think, is not necessary. But that's not my question.
Okay.
What you're saying all sounds, terrific, but this monitoring of our treatments. How much time is that going to take? There's far too much bureaucracy in the United States. Here practicing as a doctor. Oh, compared to here, yeah. I mean, we're very lucky compared to you.
Right.
In the hospital system...
So you're talking about payment administration.
In the hospital system, the way it works is ridiculous, but let's not go there. The bureaucracy makes me sick. Yeah. And if I was in charge, we'd save a lot of money, but that's another issue. But how much is it going to cost in time and money to collect this data that is important to look at, but to collect everybody? I mean,
okay, so let me, it's a fantastic question, and it's really you know, it goes to the heart of one of the three most important things that we need to do vis-a-vis doctors, which is to decrease the burden rather than increase the annoyance burden. So an interesting thing has happened to me over the last 6 months, I would say, which is for the first 5 years after passage of the Affordable Care Act, I'd go to hospitals and doctors' meetings, and I would get a chilly reception, either outright negative, attack, can't stand the Affordable Care Act, horrible, blah. And in the last 6 months, the attitude has completely changed. And I note this by I teach a course at the University of Pennsylvania on the future of the American healthcare system, and we have a physician panel every year for docs to say, you know, this is how I practice, this is the effect of the Affordable Care. Suddenly, in the last few months, that physician panel, great. Fewer gaps in care, more continuity, patients are coming in, I'm able to do preventative stuff, they're actually doing the preventative stuff. And you know, the burdens that I was really fearful of, like collecting and reporting the quality data, blah, you know, A, it's not that bad, and B, something's happened. The private marketplace has come in. So lots of the computer systems, oh, we've got to report this data now to Medicare, does it automatically, right? They've built the back end. Initially, wasn't there, right? There was no incentive to put it there. No one had to report. Doctors didn't demand it because they weren't reporting it. Suddenly, you've got a free enterprise system that actually is filling in that gap. So my answer to you is, initially, there will be some onerous. But if you have electronic health records or electronic billing records, people will develop the software to begin collecting those outcomes data and report them automatically. So the doc is not filling out, both having to fill out an electronic health record and then fill out a piece of paper to send in for the quality reporting. That doesn't happen overnight, and all of these changes that we're talking about aren't going to happen overnight. It's going to take a decade, 15 years to really begin putting this in. But if you don't create the incentive, you got to report, and by the way, that reporting is going to be meaningful to you in terms of payment, in terms of reputation. You know, you're never going to get the people thinking about, all right, how do we make it easy on docs?
And if this was the College of General Practitioners we're talking about, there would be a very different conversation because they're already doing it and they've got PenCat tools that go back into their system and pull out exactly those data without the GP having to touch it, and PHNs are creating benchmarks between general practices. So it could happen. Yes?
Anthony Llewellyn, psychiatrist, interloper, and medical director for the Health Education and Training Institute. Just following on from my colleague.
And how were you let in? I mean, I'm sorry.
I think I invaded someone's mind, Norman. Just following on from my colleagues, no, I was kindly invited by the college. Thank you very much. My colleague Sarah's comment about how we invade an already crowded curriculum, and every report back to Flexner talks about the crowded curriculum question, so that's well recognised. It does strike me that there's a lot of pedagogy in medical education at the moment around team-based learning, yet very seldom do we use that existing opportunity to unpack teams and the concept of teams and teach the theory of teams and how the doctors can better leverage from diversity and how teams form, etc. And if you think about it, we're forming teams all the time, particularly in hospitals. So I'm wondering if you have a comment about how can we actually embed learning around how to be a team member. And I think it's important to think of followership and leadership in this paradigm.
I take the challenge, but this is not my expertise. There are other areas I know more about. But one of the things I would say, well, let me make two comments. The first comment is, I think team-based care is going to be even more important on the outpatient side, where you're going to treat patients with, say, a congestive heart failure exacerbation or a upper respiratory infection at home. You don't need to admit them to the hospital for most of that treatment. A lot of that's going to be administered by nurse practitioners going to the home, by home health aides, and not by a doctor. And so you're going to have a team where the doctor can interface with these other providers effectively, and a lot of that's going to be virtual. They're not going to be co-located except for maybe an hour a day or something. And how that works, again, I don't know that we have solved that problem in any concerted way. That's not going to happen by flip of a switch. We're not going to move a lot of these patients or treat these patients out of the hospital that frequently. The second thing I wanted to say, and I didn't answer your question, we moved on, but by the way, I think the focus on, heavily attending to that 10% who are chronically ill and really sick and consuming a lot of resources, that's what's going to consume us for the next 5 to 10 years. But the wave after that, once we've wrung most of the savings out of those patients, is the mental health issue, the fact that your psychiatrist got me on. Because we know that mental health concerns, depression, anxiety, are substantial amplifiers of healthcare utilization and healthcare costs, and we are going to have to figure out how to screen for that and get interventions. I don't know about Australia, but in the United States, I see a depressed patient or an anxious patient who needs therapy, right? You give them go see a psychiatrist. It could be 4 months before they can get in to see a psychiatrist. That's going to be totally unacceptable. We have to actually improve that system. Now, a bunch of different places are experimenting, but again, this is one of those nuts which I don't think anyone has the perfect solution for. And I think in the 2020s, 2025, that's really going to be the focus of a lot of attention. Integrating back in the mental health care into general practice and primary care.
Yes. Can't see who it is.
Thank you very much. David Candia. I'm a professor of medicine at the University of Western Australia and the chair of the Western Australian State Committee. Just 3 comments on some of the
other coach?
Issues.
Yeah.
3 comments on some of the issues that you brought up. The first one was on use of statistics. I'll give you a real-life example. When I started one of the hospitals in Western Australia, one of the biggest issues I found was I was discharging a lot of patients at the weekend that I'd never met. And so, together with all the physicians in the hospital, we worked out a plan that we had an excellent handover on Friday afternoon with all the junior staff and the medical students, and so that we could actually determine who the patients were that could be going home. What that also had an effect on was that it actually meant that people were working through the week to make sure the best care was delivered so that patients could be discharged by Friday. It created beds that were then available for the acute admissions. What was interesting was then I went for a state WA government, State Department meeting where we had representation from all the hospitals in the state, and we're the second largest state in the world after the northwest provinces in Canada.
With a tiny population.
So people came from all over, and each of us was told what we were deficient in. And the stats that they threw at me was, in front of everyone, was, oh, your weekend discharge rate has dramatically gone down. So I had to say, well, thank you very much. You've actually supported our theory. But they didn't understand that because they saw it as a negative statistics.
Right.
The second comment was on bundled care. The private hospitals in Western Australia are already using bundled care for hip and knee replacements. And that has had a major effect on quality of care. So orthopedic surgeons are given $20,000. They do excellent preoperative assessments. They do excellent operative management. They lose complete interest in the patients after the surgery. So if they have an acute heart attack, a stroke, pneumonia, which we've seen quite frequently, they're not interested. And so we then have to treat the patients with issues then with payment from organizations. And GPs, primary physicians in the state, are particularly affected because they then have to take out stitches and staples with no reimbursement because that was meant to be done by the surgeon. So
let me tell you how you solve that problem.
Yep.
Okay? It's all in how you structure the bundle. So here's the structure of the hip and knee. I've spent a lot of time thinking about the hip and knee bundle because so pivotal in the United States. I don't know about Australia, but in the United States, hospitals make money on 5 and only 5 things: neurosurgery, cardiac surgery, transplant surgery, hips and knees, orthopedic surgery and back surgery, and cancer. Hips and knees are one of the biggest profit-making centers, and you got to get their attention on it. So first of all, you want to have shared decision-making so that patients know what they're getting into, and if you do it right, somewhere between 25 and 35% will say, I don't want that surgery, actually. It's not really the... Second, you do have to cover the entire operation and pre. Third, you have to cover the whole rehab. You have to make sure that they report data out to 9 months at least, if not 12 months. And so they don't get the full bundle. They don't get that full payment until they report the patient outcome. And the last thing is you want a 90-day guarantee from them. Anything that goes wrong that's related to that surgery, right? MI on the table or post, surgical site infection, they're responsible. They have to pay for it so that they're not skimping and they're not saying, oh, I finished the surgery, you know, I'm done with this case. If you don't have that guarantee in, quality is like, you know, it's like the Wild West.
Yeah, totally agree. That needs to be done. The third thing is on the educational element. The one thing that hasn't come out very strongly today is on role modeling. The research is really quite clear in educational literature, particularly from trainees, that role modeling is the #1 aspect of how they would change practice. So yes, the curriculum is packed. Yes, there are a lot of things that we want to do. Yes, doctors and students are getting more and more stressed because they're having to complete more and more assignments. But if they were working in environments where people were passionate about performing the best form of care, that will actually be a very good inducement for the future generation of doctors.
And the big problem there is you have to train people who are out in practice and re-educate them. And the problem with that is it's very difficult and hard to do because they're busy clinicians and practitioners. And
so you're creating a new role model that doesn't exist at the moment.
Well, that's one of the big challenges.
And that's where colleges like this are important, because absolutely. That can be part of the accreditation.
Thank you very much, Dave. And I think we've well eaten into drinking time.
Oh, okay.
Could you please join me in thanking Ezekiel Emanuel?
Thank you.